Hello, you've tuned to this week's episode of Next Steps Forward, and I'm your host, Chris Meek. As always, it's an honor to have you with us. Next Steps Forward is committed to helping others achieve more than ever while experiencing greater personal empowerment and well-being. My special guest today is Dr. Robert C. Smith. Dr. Smith is the University Distinguished Professor Emeritus of Medicine and Psychiatry at Michigan State University and one of the nation's leading voices on patient-centered care. In his 2025 book, Has Medicine Lost Its Mind? Why Our Mental Health System is Failing Us and what should be done to cure it, Dr. Smith takes us on one of the most urgent challenges in healthcare today, the failure to fully address mental health within our medical system, and he offers a path forward. Dr. Smith, thanks so much for being with us, and welcome to Next Steps Forward.
Chris, thank you for inviting me. I'm looking forward to it.
So first of all, before we start, my listeners and viewers know I'm a huge sports fan. How's Michigan State looking next year in football?
It's iffy, but
Okay.
but basketball with Tom Izzo is always good. It's always top of the hill.
He's legendary, so you're always in good hands there.
Always a wonderful person as well as coach.
I
All his players graduate.
That is very uncommon in today's world.
Yeah.
So, Bob, let's start with some history. You literally helped to transform how physicians communicate with patients by helping to pioneer the patient-centered interview. Was there an aha moment when you realized we're missing something important in how we care for patients?
Yeah, it came. It wasn't aha. It came rather slowly. I had learned how to do this and was doing it, and I was teaching residents about it, and I realized I kept teaching the same thing over and over. And up to that time, there was no real guidelines for how you conducted a patient-centered interview. And I realized I was saying the same thing over and over. And so I talked to one of my colleagues, Ruth Hoppy, and she said, well, why don't you write a paper on that? And I wrote a paper. She joined me on it. And it proved to be the beginnings of this patient-centered method. And I refined it a bit after that. And then in 1996, the first edition of the interviewing book came out, where we finalized the specific model. And that basically, it wasn't an aha moment, although I had an aha moment each day when I was teaching residents, because I'm getting tired of saying the same thing over and over.
Sorry, I put on mute so you didn't have to listen to my dog, Zeke.
I hear Zeke.
Yeah, he's just letting you know that my boiler guy's out front. When did that change in doctor-patient interaction take place? And I imagine it didn't happen overnight. How long did that take to change that process?
Yeah, it actually began clear back in 1977. George Engel identified the so-called biopsychosocial model, which basically says you integrate bio, which is biological or physical disease problems, with psychological and social issues. They all go together. Now, that's not what modern medicine does. It focuses just on the physical disease. But in any event, back in 77, he identified this model as based in general system theory, which is the modern theory of science. He identified this model, but the problem with it was, how do you obtain just relevant biopsychosocial information from the patient? You certainly don't have time or the desire to obtain all biological, psychological, and social. Take days to do that. And so how do you obtain just what's relevant? And that led to the whole field of so-called patient-centered medicine. Ian McWhinney at Western Ontario soon came along and identified what it is to be patient-centered. And in essence, Chris, what it means is relinquishing some control, not asking all our disease-oriented questions, and rather hearing what the patient has to say. And following that just unleashed a ton of research and ideas and theories on how to do it. It was not easy to put together. And basically over the years, what happened, I trained then at Rochester, University of Rochester in upstate New York with Engel. And so I was informed then, we did patient-centered interviewing, but I became impressed that nobody was teaching it the same way. Some people said interrupt, other people said don't interrupt. And so it was pretty vague and it was not reproducible. One teacher would do it entirely different from another. And it was with that, building on the shoulders, as it were, of all these giants that had come before me, that I kind of stumbled into this in teaching my residents, because I was saying the same thing over and over. Well, it turned out that was the previously lacking method. I had somehow synthesized it without really thinking a lot about it. And that's what then we produced that. And then, Chris, it's interesting that the method has become very popular because it's evidence-based. We can establish it. Because we identified specific steps and behaviors, there's 5 steps and 21 sub-steps that you conduct generally in about that order. It's not rote, it's flexible, but these are kind of signposts that you identify as you go through the interview. Because we could identify specific skills, people could all teach the same thing in that sequence. Importantly, it also let us define the patient-centered interview so that we could conduct research on it. Before that, it was hard to conduct research because you couldn't really pin it down. So, and we conducted, a couple of randomized controlled trials, showed that it's easily learned and it's associated with improved health outcomes in patients. And so that's the long and short of that. That was the first edition back in 1996, and we're now preparing it for the 5th edition. And so it has taken a nice step, again, on the shoulders of all the giants that came before, from 1977 up to 96 or so, because there are a lot of people, there's a lot of work. Being at Rochester and subsequently in what was known as the Academy of Communication in Healthcare, became exposed to all of this and all of the skillful stuff that people were already doing, and also became aware of some of the problems yet that had to be solved. And so it was a wonderful experience for me, and I kind of came along at the right time.
Better lucky than good, right? So we know that physicians are among the smartest, the best educated, and certainly the most compassionate people in society. Why do you think the interview process wasn't patient-centered from the very start of physician-patient relationships?
Key question. And there is a very clear answer to it. Medicine, since the 17th century, scientific revolution, has focused just on the physical body, to the exclusion of mind and social, psychological, psychosocial, whatever term you want to put on it. Spiritual gets into there, psychosocial, spiritual. All of these issues have been dismissed from medicine. And so it comes on up into medical education today. Only 2% of total teaching time is devoted to psychosocial factors, which includes mental health. And this is out of the 15,000 or so hours that a doctor goes through. This is 4 years of medical school, 3 to 5 years or more of residency. And all they hear is physical disease, physical disease, physical disease. And in a realistic sense, they become kind of brainwashed to it. I mean, that's all there is to them. And I mean, the story is quite sad. Mental health, mental disorders are the most common health condition in the U.S. today. They're more common than heart disease and cancer combined. And yet we only spend 2% of training time to them. And that plays out in a terribly painful way. Primary care doctors like myself are conducting 75% of all mental health care, but we're not trained for it. We get 2% of total teaching time. And so how does medicine come about to be not training its doctors for the most common health condition they see in practice? Has medicine lost its mind? That's where the title of the book came from. I was giving a talk one day and made that same statement. Is that spontaneously, has medicine lost its mind? No, there's the title of the book. And so it's a terrible situation. And there's no bad people in this. Medical people are not bad people. They're not trying to harm mental health patients. It's just that is the way it's always been. And at least in my opinion, and I think that of most mental health advocates, certainly, it needs to change. I mean, psychiatrists today see no more than 12% of all mental health patients. The idea in medicine has always been, well, psychiatry will take care of that. We'll do the real stuff, and psychiatry can handle all that touchy-feely stuff. But there's never been enough psychiatrists, never. And I mean, another problem is that medicine excludes psychology. Psychology is a rich, rich resource, but it is outside of medicine. And so the long and short of it, they need more psychiatrists. They need to bring psychology in, and especially need to start training the primary care doctors who provide almost all mental health care.
Well, and to that point, in a post-COVID world now, all you hear now is the need for more clinicians. The one positive thing I say about COVID is it put a spotlight on mental health, and people now say it's okay to not be okay. But you're limited by state regulations, your state licensing. During COVID, there was a temporary lift on the ban where you could go across state borders. And so, to your point about only 2% of the teachings were in the psychology and psychiatry space, what were the biggest challenges you encountered trying to bring mental health into primary care conversations?
It is this same, I didn't go into it, but let me explain it, because this is a very, very well entrenched attitude. Let's go back 16th and 17th centuries, scientific revolution. Up until that time, the church had governed all of society, including science, with an iron hand for well over 1,000 years. But science, and it wasn't just medicine, it was physics and chemistry and math and so on, we're starting to want to come out of the dark ages, and we're starting to get some traction. In medicine, the basic science at the time was human anatomy. But the church had prohibited human dissections. They viewed them as blasphemous. And so at that point, medicine's understanding of anatomy was derived from dissection of goats, pigs, cows, and the like. And of course, it was erroneous. But that's the way it was. That was so-called dark ages of medicine and science. But medicine was pushing. He said, we have got to dissect the human body. We can't do this without it. And finally, in 1537, Pope Clement relented. He said, okay, you guys can dissect the human body for teaching purposes of physicians only, but I've got one proviso. The head must be removed from the body before the dissection starts. The head, that's the source of the mind, the soul, and the spirit. That belongs to the church. We keep that. You guys get from the neck down. You guys get the physical body. And this launched, Chris, what's known as the mind-body split. Medicine got the physical body. Now, that was just a minor beginning, because in the next century, along comes Rene Descartes, John Locke, and a host of other philosophers. These are the people who really cemented, and again, it's called the mind-body split. They're separating the two. Prior to that time, doctors had always seen it was integrated. They didn't see one as different from the other, but now they're separated. And this then progressed up into clinical medicine. Doctors now started looking just for physical diseases. They forgot what your job was, or who your wife was, or what your kids were doing, or what you were eating. That didn't make any difference any longer. Doctors now got focused on that. And I'm telescoping a lot, of gone over a couple of centuries here, but it became highly successful come the 1900s. Up until that point, it was more in the diagnostic aspects of medicine. You could find a diseased liver, or a heart failure or something like that. Doctors could diagnose it, but treatment didn't really begin until the 1900s. And that's when ether, chloroform were discovered. All of a sudden, you could operate on people and amputate a leg in the wars. That was commonplace. Pull a tooth. Instead of overdosing them with alcohol and holding them down, they could now be put to sleep. Dramatic advance. Penicillin was discovered. Sulfa was discovered. People lived who received these drugs and were well in 5 or 6 days, where previously they were dead by then. And so these are dramatic changes. Medicine had now turned the corner. The mind-body split not only helped with diagnoses of physical disease, but it's now paying off in spades. And through all of the last century, drug after drug was discovered. Beta blockers, all kinds of hypertensive medicines. We have GLP-1 agonists today so people can lose weight. Surgery advanced. We're transplanting hearts. MRI machines peer into the depths, electron microscopes. You can see things at an atomic level. And it's just on and on and on. This has been incredibly successful. Life survival, Chris, in the last century doubled from 40 years of age to 80. There had never in the history of medicine, from the time of Hippocrates in the 5th century BC, had been any benefit from medical treatment. All of a sudden, we've doubled life survival. Now, part of this is controlling epidemics, vaccinations, polio, smallpox, all of that stuff. Just dramatic advances in physical disease medicine. And so that's why doctors focus today, in answer to your question, on just the physical. And they're trained that way, to focus just on the physical. The problem that came out of that was medicine's success bred its failure. Medicine, in extending life survival up to 80 years of age, cured all the acute problems, and they were taking care of the chronic disease problems, and the epidemics and things were gone. And so what surfaces now is a new population in medicine: mental health and chronic physical diseases. Both of these require attention to the excluded psychosocial, emotional factors that medicine excludes. It's obvious in mental health, you can't exclude psychosocial mental factors and take care of mental health. But chronic diseases also require attention to psychosocial factors. And we can go on to that if you want, but I'll stop for a second here.
No, this is fascinating. One of the benefits of having this show is just learning something. And you know,
Yeah.
science was never my thing. Physics, I was okay at, but biology and chemistry, not so great. And so just learning the history aspect of it, and
Yeah.
especially the whole, you know, the mind body split with the church choosing
Yeah.
that, like that's fascinating.
Yeah. No,
And
in fact, some people back then took a little more jaundiced view of it than I've said. It wasn't so heartfelt by Descartes that he believed that. They said, remembering the church was incredibly powerful and science was trying to get in. Some of them said it was just a grand compromise with the church. You take the mind, we'll take the body.
that sounds about right. So you mentioned earlier about how you were giving a talk and you came up with the title of your book, and obviously it's a provocative one. What observations and experiences prompted you to ask, has medicine lost its mind?
Yeah, it comes back to some of these issues. When you look, Chris, at mental health today, and again, it's being conducted mainly by people like me that are untrained, and God bless us, and we've tried our hardest, and believe me, doctors like me and a ton of other primary care doctors have worked hard and done better than you'd expect for people without training. The downside, however, and this isn't just poor mental health care, some of it is just absence of mental health care. Only 25% of all people with a mental disorder receive any care. This contrasts to 80% of people with physical problems. And so a lot of mental health care is just being overlooked. But what happens, and the real downside of this, I think people often don't understand. In fact, I think the public often thinks their mental health care is just as good as physical disease care. Why wouldn't it be? You go to the doctor for what's wrong with you. But that's not the case. There have been, you've heard of the prescription opioid epidemic with OxyContin. That's killed over 200,000 people. These are doctor prescribed OxyContins and other narcotics. Doctors are not trained in the use of narcotics for chronic pain, which is why almost all of this is given. Now, things have gotten better, but there's still something like 15,000 deaths per year from untrained, doctor prescribed opioid. And again, it's not their fault. I don't mean this to be critical of medicine. It's just not their fault. Suicide, another one. There's 48,000 suicides a year. Almost half of these people see their doctor in the 2 to 4 weeks before they commit suicide. Ideal time. Identify that they're suicidal and get something done about it. Doctors aren't trained in suicide. They don't know how to suspect it or recognize it. And it's more than, you're not suicidal, are you? If doctors address anything, it would be in that way. And of course, nobody's going to answer yes to that. And so this is an opportune time to prevent this, but that doesn't happen. You could maybe save 20, 25,000 people a year if doctors were trained. And the carnage gets worse. I mean, we're talking here tens of thousands of unnecessary deaths because mental health problems are not recognized and treated effectively. There are almost 100 million people in this country with a major mental disorder. Within that, there are tens of millions of adverse consequences from failure to recognize and effectively treat mental disorders. Unnecessary divorce, poor job performance, school failure, addiction, incarceration, homelessness. I'm not saying all these things can be prevented, but they certainly would do a lot better if the mental health disorder driving many of them was recognized and effectively treated. And so the carnage from this is just terrible. And I don't think the public understands this. I think most of the public believes that their mental health care is as good as their physical disease care, and it simply isn't.
You mentioned about the suicide rates and the tens of thousands of unnecessary deaths. Where do patients most commonly fall through the cracks? Is it with access, intake, diagnosis, follow-up, all the above?
It's mostly not recognition. I mean, only 25% of all mental health patients are even treated. And that's mostly by primary care doctors who are not trained. That means 75% of this nearly 100 million people aren't even recognized. There's no opportunity to come into treatment, much less effective treatment.
What does a truly collaborative doctor-patient relationship look like in practice?
Doctors right now can have good relationships. It goes back to some of the things we were talking about earlier. If one is patient-centered, you give the patient the opportunity to talk. It's not a matter, though, of just sitting back and listening, because you couldn't do that. You could maybe spend a half hour, and doctors don't have that kind of time. But the patient-centered method that we have described is very efficient. You can conduct it in 2 to 3 minutes with most people. And in fact, if anything, it saves time, but it certainly does not take more time. And so what that does is it allows you to be heard by the doctor instead of being asked, where's the pain, what medicine are you taking, da, da, da. Excuse me. And the doctor starts to hear their personal life. Maybe they came in with pain in the back. Well, they hear that that's interfering with their job. Now, many doctors ignore the job, but here a patient-centered approach would say, well, tell me more about the job. Well, I'm afraid of losing it. How does that make you feel? I'm depressed. And the pinnacle of being patient-centered is to get to the emotion the patient has. This is now getting to your question, which is, how do you establish the relationship? By identifying the personal story and the emotional context of it, and it may be due purely to a physical disease problem, but there's always an emotional component to somebody, say, with refractory heart failure or diabetes or COPD. And so you get to the emotional component, and you then have to address it. And often the doctor's worst fears have not been realized. There's somebody expressing emotion in front of them. They're angry, they're crying, they're sad. What do I do with that? Doctors don't know. We're always told, be empathic. That doesn't mean anything to most people because they don't tell you how. The patient-centered method tells you how. And I'll tell you here in brief exactly what it is. We're doing kind of a role play here. The mnemonic nurse, NURS, describes the empathic skills. The N is naming, the U is understanding, the R is respecting, and the S is supporting. And I'll do it now. And somebody you might have heard is out of it, or they're worried about losing their job. How do you feel? Upset. So you're upset. And I can understand that. That's been a tough time for you. R, respect. Let's work on that together, you and I. That's S, that's nurse. And you then you don't use them all four at once like that, but you kind of sprinkle them through the discussion. And it is in using these empathic skills that the relationship is developed. That's where the collaborative relationship you're talking about, Chris, comes from.
Sorry, Zeke was barking again. For years, we've talked about the stigma that lay people in society often attach to mental health issues and treatment. Do some people within the medical and insurance professions also stigmatize mental issues? And if so, do those attitudes also contribute to the ongoing failure that you've identified?
Yeah, that's a key problem. We've talked about the mind-body split, okay? It permeates all of medicine. The insurance companies, the hospitals, the drug companies, the equipment companies are all focused on physical disease medicine. And unfortunately, they, as occurs in medicine, with this undue emphasis on physical diseases, not only do doctors not become skilled in them, they often develop negative attitudes toward them. For example, a professor might say, oh, don't ask them that stuff about their emotions. We don't deal with this touchy-feely stuff. We're here to answer questions about real disease. That stuff's not important. And it's a so-called culture of medicine, Chris, that we're talking about. It not only excludes psychosocial, but it disdains and dismisses it as not important. Now, many people in medicine will say, well, no, we believe all that. But they're still not teaching it. But there is a thread, a strong thread. I mean, there's an example. When medical students begin medical school, I think the figure is in the British Journal of Psychiatry, the figure is something like 49% are very interested in psychiatry and in mental health. They graduate 4 years later, and that figure is down to 4%. Something is happening to them during that time that medical education is beating that out of them. Now, some of it is lack of training. During that time, only 4% of their 15,000 hours of training is in mental health. So some of it's due to that. But there are also these negative attitudes toward mental health, stigma, if you will, that occur during that time. And when they go into residency, it's even worse. Medical schools teach maybe 4 or 5% mental health. Residencies teach almost none. Now, family medicine and pediatrics are exceptions to that. They do much better. But the overall figure is 2% across 7 or 8 years of training. And along with that is this baggage of stigma towards mental health.
And would you share some real world consequences for patients that you've seen or heard about when the system's going to diagnose this wrong, or they just miss it altogether?
Oh, sure. There are many, but I guess what comes to mind is I was seeing a patient once, and he was sent to me. I think I've got this right. He was being sent to the mental institution. He was severely demented. He come from a primary care doctor and neurologist who presumably had only 2% of total training time in mental health. Okay. And I'm seeing him, his daughter is with him. And I say, so how are you doing? What month is it, do you think? And this was in the middle of winter. And he said, it's June. What year is it? And he was off by multiple years and so on. But his daughter, in talking to him, he sounded demented. But his daughter, and it's important to pay attention to relatives. His daughter said he's crying all the time. And he doesn't eat. And he keeps crying. And his wife died just 2 years ago when all this began. Long story short, he was depressed. He wasn't demented. I mean, he was in a hospital for about 6 months getting this treated because it was severe depression. That's what they call pseudo dementia. It's when depression presents as dementia because it's so severe. And in any event, he finally back. He played golf, not that year, but the following year a little bit. This guy was otherwise headed to the mental institution where he'd be to this day, vegetating and depressed. And I mean, I mentioned earlier, unnecessary divorces happen. People fail at their jobs. People get addicted to medications and they don't do well in school. I mean, it's over and over and over again. If these problems are recognized, we can prevent tons of these sorts of complications.
The second part of your book, Has Medicine Lost Its Mind? The subtitle is What Should Be Done to Cure It? How optimistic are you that medicine can find its mind again?
Yeah. That's what we're working on. And my idea is that medicine is too locked. They're locked into this mind-body split. I don't see a way out of this with medicine running itself as it does. Medicine's a pretty insular profession. There's not much input into how you run it. And they've been teaching less than 2% of mental health since the 1900s, since modern medical education began in about 1910. And they've been doing it. And I mentioned Dr. Engel inventing the biopsychosocial model back in 1977. At that time, and since then, people within medicine, and there are many people that talk like I do in medicine, I'm not the only one by any means, we have been urging medicine to change, become, incorporate the psychosocial, emotional, mental. This is actively since the 1970s. And it goes in one ear and out the other. They just don't do it. And so I've concluded, in fact, that's how I got into this business of writing this book, was I got fed up with talking to the wall, as it were. We were writing research grants and doing stuff, as were many other people, but nobody's listening. And so I decided to go to the public. This is why I'm talking to you. This is why I wrote this book. I'm on a mission to change this. And medicine is not going to change of its own accord if they're too locked into this. And what needs to happen is that, I mean, Hannah Arendt, a famous historian and philosopher, weighed in on this issue. Who determines the direction of a science? Big question. We're wrestling with it right now with AI. Are we going to run AI or are robots going to run us? I think we're deciding we're going to run the robots. Test tube babies, past issue came up. Public decided we are not having test tube babies. So that the public has a powerful influence on the direction of any science and indeed any activity. The Vietnam War ended because of the public. ICE in Minneapolis ended because of the public. The public is powerful. And so medicine will not change unless it has pressure from above. And as I said before, most in medicine, or most patients don't know how bad their mental health care is. They think it's as good as their health, physical. And so what needs to happen is that we come down from the top. Does this work? I've said Vietnam War, these sorts of things, test tube babies, it works there. Well, it has worked also with refractory institutions like medicine. Ralph Nader, you probably remember his book, Unsafe at Any Speed, came out in the early 60s, 61 or 62. Unsafe at Any Speed blew the whistle. And this is the operational statement here because I'm blowing the whistle on medicine. Nader's book came out and blew the whistle on the automobile industry. They had seat belts. They knew they worked, but they didn't want to use them. They're afraid the public wouldn't buy them and they'd lose money. And there were a host of other problems. Nader's book came out and absolutely infuriated the public. I can remember reading it myself and thinking, my God, how could they do that? Long and short of that was the public became furious. They demanded their politicians do something. This led to the National Motor and Traffic Safety Vehicle Act. And that's why, and here's the benefit of doing this, we have the safest automobiles today that have ever existed. I mean, it worked. The public had an input and it paid off. Then, back at the same time, Rachel Carson wrote Silent Spring. Chemical industries at that time were polluting everything they touched. It was so bad, there was DDT in our drinking water. Didn't do anything about it. Would have cost them money. Why do it? Things are going okay the way it is. Until Rachel Carson's book came out and blew the whistle on the chemical industry. The public was absolutely incensed. This led to their politicians. They acted. We have the Environmental Protection Agency today as a result of that. And that's why you don't have DDT in your drinking water and a host of other protections. So my book, Has Medicine Lost Its Mind, seeks to do the same thing with medicine and the medical industrial complex. It can have, the public has to be informed and insist that their politicians do something. So as we can talk about what they might do if you want, but that's another topic.
Well, we can actually. That might be a good segue for the next question. So as you're blowing the whistle now on the medical industry, how can we better integrate mental health into everyday primary care?
It will require, and in doing this, Chris, what will happen is that once the politicians get involved with this, medicine will start teaching mental health on par with physical disease health. This, within a matter of 5 years, will start to have an effect on public mental health. It depends on how fast they go and how fast they move and how much resistance there is and so on. But it generally, you can start turning out classes of much more skilled people in 4 or 5 years.
Two things you devote your professional life to are what patients wish their doctors knew and vice versa. Let's tackle those topics one at a time. First, what do patients understand about their own health and lives that medicine professionals can or do overlook?
The patients, Chris, are the authority on what they have. Your interest, your feelings, your pain, whatever it is, you are the authority on it. Doctors only bring to it the ability to relate, being a patient-centered way, relate, find out what the relevant problem is, negotiate its treatment with the patient, and they are expert then in diagnosis and treatment. But the patient is the primary input into that. The doctor does not decide what the patient needs. The patient decides.
And how often do patients recognize the emotional roots of their symptoms, but struggle to communicate that information?
Yeah, people, this mind-body split, Chris, permeates all of society. I'm sure in your experience, and certainly in mine, and probably in most of your listeners, they have been taught since they were 4 and 5 years old not to express emotion. Do not ask people about it. Do not express it, especially little boys. Don't cry. And so, and in fact, to go back historically, there was a scientific revolution, mind-body split. We're now up into the age, what was called the age of reason. It was the next century, the 18th century. And the operational word here is reason. Be logical, be reasonable, think, be analytical. Don't express emotions. Mental health people, there's something bad wrong with them. Stay away from them. This is where stigma comes. It all comes out of this mind-body split that we talked about in society. And so that's the origin of much of this dismissal within society. Now, society is much farther ahead in reintegrating this than medicine is. Medicine has made very little progress. Society is doing better. I mean, people are meditating and, trying psilocybin and various drugs and God knows what. But people are raising this to consciousness. And so society is much more aware of it. Although I would say that when you see patients, you can't just see a patient and say, "What's your emotion?" That doesn't work. It's just like saying, "Are you suicidal?" They're going to say none. One has to be patient-centered with them to be able to identify the emotion. Or, largely, a non-physician friend or spouse should interact with the other person in a so-called person-centered way, in which they do much the same as what I've been talking about in medicine. So, tell me how you're feeling. They listen. They don't ask questions, and they don't start spouting off their own problems. They listen. They hear the problem. They inquire about its emotional component. They nurse it. I understand. It's been a tough time for you. Let's work together on this. That's the way people and routine day-to-day activity interactions come to not only express emotion, but in turn, that leads to a closer relationship between the people engaging in that interaction. And so emotion is at the centerpiece of much of this, and it is what has largely been suppressed, as you were alluding earlier, Chris.
For people who are going to their doctors today or soon, what are the most important steps they can take to advocate for more complete integrated care?
Yeah, that's a difficult question, and I don't have a good answer for it. The best thing they can do is to be aware if they have emotion, if they think they have an addiction problem, if they think they're depressed, if they're anxious, if they're failing at work or school or something, or if people are telling them they have a problem. You've changed, your grades are going down, something like that. Is to be upfront when you go to the doctor. Look, doc, I think I've got a problem. I'm depressed, I think. And to make it explicit. If that doctor, probably untrained, but maybe having done lots of work on her or his own, is capable, they may be able to work with you around that. If not, or if they seem disinterested, then you should request a referral. I often suggest a referral to a psychologist, because some of this can be handled by the counseling that they do, and they would decide then whether a psychiatrist needed to be involved for medications, which is largely what psychiatrists do today. Psychologists are probably easier to get into also. Psychiatry, particularly in some areas, is almost impossible to get into. But this is that. Don't be shy if you feel like you have a problem. Mention it, push it, and if you're not satisfied, go see somebody else.
Doctors often caution patients against diagnosing themselves based on what they read and see on the internet, and my wife is 100% guilty of that. You've been practicing and teaching for decades. What is your opinion on the internet's influence on patients and their relationships with their doctors?
You mean from the internet? That's
yes.
Yeah. No, I'm the old issue before the internet and stuff was that people would come in with a list of things they wanted to talk about. That's good. Do it. That means you've thought about it. You can tell the doctor and so on. That's good. Doctors were taught to shake their head. No, somebody's got a list, and that's good. Do it. Bring your list. Then we know what we're addressing. Same thing with the internet. Read it. Go into it. You need to be careful you're not getting some bogus stuff from AI, but read the internet. Be informed. There are many television programs and things on today on health, but be informed. Check with your doctor, though, before acting on it. Be careful about all these things with vitamins. They're going to do this and that, and another one's going to make your thinking better, and another one's going to make your eyes shine. Be careful. People end up spending billions of dollars on these things. And before you take that to heart, check with your doctor. Do you really need to take that? And there's now all these advertising directed at specific conditions that I'm sure you've seen. See your doctor first.
I think the disclaimer is longer than the commercial on most of those things.
Yeah.
So we've got about a minute and a half left. As you look to the future, 5, 10, or even 20 years from now, how do you hope doctor-patient relationships will evolve, and what do you think they'll actually look like?
Yeah, what I think is that mental health is going to, I think there will have to be what's called a supraordinate control over medicine. And this isn't socialized medicine. Medicine will still practice however it wants. They will determine it. But there will be a supraordinate body. Don Berwick calls it the Health Accountability Board. This will be a federal agency like the Federal Reserve, independent of politics, and it will run medicine. And it will run it in a biopsychosocial way so that these blind spots that medicine now has of not training in mental health care will automatically go away. Research will be governed by it. Profit making by the insurance companies and drug companies and equipment companies will be controlled. They'll still be able to make money, but they won't make as much. And so this board will control that, just as the Fed today governs banking. They do stress tests here and there, and they keep the banking system in order. The medical system will be kept in order by a healthcare accountability board if the public gets active and insists on it. And the public needs to know that they are now receiving inadequate mental health care and inadequate chronic disease care, and that medicine will not change on its own.
That's a great way to close the show, Doctor. Dr. Robert C. Smith, author of Has Medicine Lost Its Mind? Why Our Mental Health System is Failing Us and What Should Be Done to Cure It. Thank you so much for being with us today. And like you said before we started, we had a lot of stuff to go over, and we got through maybe a third of it. So I have to have you back on the show if that's okay.
Love to see you again, Chris, sometime. Thanks for having me.
No, thank you. I'm Chris Meek. We're out of time. We'll see you next week, same time, same place. Until then, stay safe and keep taking